Welcome to Variations 4, the GI unit. Today we'll be covering questions 1 through 7 in this video, with the primary focus being ulcerative colitis and Crohn's. Number 1, just a quick overview of what is gastroenteritis. Looking at map 1. What does itis mean? Itis means inflammation. And so what could cause inflammation of the stomach, small intestine? You got 3 things listed up here at the top. So a virus, bacteria, or a parasite could cause inflammation. Okay, what kind of symptoms do we expect from gastroenteritis? Very broad question. You have all these triangles here that kind of go over some fairly non-specifics, but none of these should be surprising. How we deal with nausea and vomiting, the circle here should be pretty straightforward. With diarrhea, we are worried about fluid loss. Why don't we give Imodium for the diarrhea that accompanies the C. diff infection? We don't give Imodium because we want the infectious agent to leave via the stool. So for C. diff, we would not give Imodium because the agent is removed via the stool. We would give antibiotics, anti-infectives, we would replace fluids, but we would not give Imodium. We would monitor lights. For fever and high white blood cell, fairly non-specific signs of infection, these should make sense in the circle. Okay, irritable bowel syndrome is not what we're talking about in this course. Don't get that mixed up with inflammatory bowel syndrome, IBD. Otherwise known as inflammatory bowel disease. That is what we're talking about, and we're really focusing on Crohn's and ulcerative colitis in these next few questions. So Crohn's, ulcerative colitis, what are some factors that play a role in either causing the disease, passing it on, or causing an exacerbation, a flare-up of Crohn's or ulcerative colitis? These rectangles here at the top list off either factors that are causative in nature, such as genetics, and factors that will cause the signs and symptoms to worsen, such as stress. So we've covered questions 1 to 3. Now question 4, we'll cover question 4, 5, and 6. Actually, sorry, 4 and 5 together now. Both of them are on map 2. And I think while we're doing that, we might as well talk about these 4 conditions, how they could be caused, how they can happen as a result of an exacerbation of inflammatory bowel disease. Where does ulcerative colitis occur? It's in the name, in the colon only. Where does Crohn's occur? Most often in the ileum and colon, but it may occur anywhere in the GI tract. Now, don't forget the GI tract runs from the oral cavity all the way down to the anus. Theoretically, the inflammation can occur anywhere along that passageway, but most often occurs in the ileum and colon. Inflammation is a big theme in this course, so it's really important that we have a good understanding of the inflammatory process, or a general understanding that we can apply. So just taking a break from this diagram for a minute, let's just talk about inflammation in general. What is the purpose of inflammation? To send fluids, helper cells, cleanup cells, fighter cells over to the area of assault. So, for example, when you cut a finger, you see reddening and inflammation around that cut. That's the inflammatory process. The body is sending fluids and basically cells to help fight and clean up and contain the area. How do we get all that fluid to the area? There's vasodilation that occurs that helps fluids to get to the area, and an increase of fluid to that area. That's something we want to keep in the back of our minds throughout the course. A second principle of inflammation is that if inflammation is severe, or more commonly, if it is chronic, keeps happening over and over again, what happens is that area of tissue that was inflamed starts to thicken. It can't do its job properly when it's thickened. The cells of that area lose their function, and you end up with thick fibrotic tissue in that area of repeated or intense inflammation. So back to the diagrams here. When we have inflammation in the colon, it leads to a thickening of tissue, as we just talked about, and a narrowing of the lumen. This is obviously a problem for stool and even water trying to pass through the bowels, as they can become obstructed in the narrow lumen. So there we've answered that one question of how can obstruction occur. What are the symptoms of obstruction if someone has an a bowel obstruction? As a triangle suggests here, bowel sounds may be absent. Why is that? A couple of thoughts. First of all, remember the thickening of the lumen means the cells can't do their job. It means peristalsis will not be effective in that area, as well as food and fluid could get trapped in that area. Number two, the obstruction could put the bowel into shock, and so peristalsis ceases throughout the whole bowel. So you may have absent bowel sounds throughout the abdomen. Alternatively, you may have higher pitched bowel sounds just before the point of obstruction, and then past the point of obstruction, absent sounds where the bowels are not working. Most commonly in surgery, when we see obstructions, we have absent or diminished bowel sounds. That's been my experience. Okay, onward with this diagram, working our way through it. So inflammation causes these ulcerations in the mucosa, and those in themselves contribute to that fibrotic tissue we talked about. But the mucosa at times of inflammation is thin, it's more delicate, and there's a risk of perforation. There's a risk of perforation because of the obstruction itself, and there's a risk of perforation because the lumen wall is compromised because of these ulcerations. So there's a risk of actually perforating the bowel wall and then blood seeping out into the abdomen in a hemorrhage, or stool seeping out into the abdomen causing peritonitis and sepsis. Either one of these could lead to shock. And now a more general part of the diagram here, if I was to ask you what are some of the common signs and symptoms of someone who comes into hospital with a flare-up of Crohn's or ulcerative colitis, these are fairly common here. We want to add to this list here bloody stools, low hemoglobin. You've got an absorption problem as well, obviously, with all of this going on. And they can end up with either dehydration and lights imbalance. And the diarrhea is kind of like the bloody stools as well. Okay, and I believe we're on to the last question for this video. That is, review the head-to-toe diagram on 3. There's a note here about surgery with the 2 conditions. You may want to read that later. Let's look at this head-to-toe diagram here. So someone who comes into hospital with a flare-up of Crohn's or colitis, go ahead and read through this list, maybe on your own, pause the video, read through it. I think most of it's pretty obvious, but I will talk to some of the points. Why counseling for lifestyle changes? It depends on what the patient's going through. I've met many patients who are in their 30s and 40s who have a difficult time with holding down a job because of the flare-ups of these symptoms, sending them into hospital so often. It could be counseling for lifestyle changes because they've had surgery and now they have a stoma and the body image issues. I think most of these are obvious given what we've talked about above, the complications that can happen. Bowel rest, what's that? If someone comes in, and typically what we find is that when someone with a flare-up of Crohn's or colitis, when they eat, it makes it worse because they have ulcerations in the mucosa. Eating releases digestive enzymes and acids, makes it more painful. Eating also stimulates the peristalsis, which brings on the cramps, which brings on the bloody stools. Or conversely, eating may contribute to their obstruction. Either way, bowel rest, which means basically NPO for a little while, is typically how we start off. Then we treat their pain with morphine or some kind of narcotic. And if they're lucky, it's just a matter of waiting it out and then trying them on a diet that's starting with liquid, working back up to solids, and then see you later. Oh yeah, they'll probably be on steroids as well to decrease the inflammatory process, corticosteroids like prednisone. If they need something more dramatic, then we might be looking at surgery, which we'll talk about in a bit. TPN is total parenteral nutrition, which we'll talk about later in integrative nursing practice. But yes, TPN is basically, in a crude form, meals through the IV. So lipids and Travasol, and we'll talk more about that goes through the IV when someone's NPO, nothing by mouth, for a few days or more than a few days. Your goal with diets is these things. They need calories like most patients do and protein like most patients, but you want a low residue diet because you don't want that kind of fibrous food that's going to irritate the bowel and contribute to their pain at this point. As I alluded to earlier, here's the classes of meds. And if you're wondering why, Well, think about what we talked about above. Why would these meds be helpful? Usually we're talking about decreasing the inflammatory response, because at the end of the day, Crohn's and colitis is an inflammatory response. Again, number of causes for that, but at the end of the day, it's an inflammation. And so we have to combat that. This is a cult blood test. So if you weren't sure if they had blood in the stool, if it wasn't, sometimes it's really obvious. If it's not obvious, we send stool to test to see if there is blood in it. If they're getting a colonoscopy, as a nurse, you need to be aware that they need to be NPO for a period of time before that test. They might need bowel prep to empty out the bowels completely before that test. Little side point before we take a break from this topic, and that is that we're talking about inflammation being what we're trying to combat here. Ibuprofen is an anti-inflammatory, a non-steroid anti-inflammatory med, but studies have found that it can actually worsen the symptoms of inflammatory bowel disease. So ibuprofen is not recommended. In the community, you see some people using ASA prescribed by the physician for mild to moderate cases. So ASA is okay if it's prescribed by your physician. You likely won't be seeing ibuprofen used, though. That concludes our topic for now.